So uh, again, thank you very much for inviting. We will be talking about the advances that are currently being used in practice. There are some wearable devices or some as of now, blood sugar monitoring requires a prick. All the prickless devices, so-called prickless devices, are not of practical use as of now. So some basics to start with. So SMBG is not optional. SMBG is a mandatory part of diabetes care. No person with type 1 diabetes can manage diabetes just by taking insulin without monitoring glucose. When we purchase glucometer, please make sure that you're looking at cost of strips and not per se cost of glucometer. I would like to add that look for whether the meter is downloadable or not. I've compared the cost of strips for downloadable versus non-downloadable glucometers, and it is not different. So go for a downloadable glucometer wherever you can. And please ensure that it is locally available. People should not have to struggle buying to purchase the strips. The pricks should be on the sides of the fingers. And it is essential to maintain a log as well as to take action on these readings. It is not only that you monitor glucose and do nothing about that. Then you'll not be achieving anything. So to maintain a log along with the insulin doses and along with some remarks to explain the high or low readings. That is the example of complete log. We'll be discussing about digitally connected glucometers, some mobile applications, CGMS, and hybrid closed-loop pump therapy. Glucometer technology has advanced in the recent past with respect to availability of smaller meters, improved memory, battery life. Now they require very, very tiny amount of blood for testing. There is improved test speed and accuracy. The methods have improved. The current glucometers provide plasma equivalents rather than whole blood glucose equivalent. It is also possible with some of the glucometers to simultaneously be able to check serum ketones, although this requires a different strip. The strip is different, but the glucometer can be the same. Many of these glucometers can be digitally connected, and some of the company manufacturers also have platforms to kind of download the readings and interpret them in a very nice, colorful format. As you can see in this one-touch download, that you have average glucose, in range, below range, above range glucose, a graphical presentation, as well as a tabulated presentation. Although for a healthcare provider like us, it becomes very, very difficult to remember password of each and every company platform and to log in at that time. And even this kind of format sometimes may look attractive, but when you actually sit to interpret the readings, it may kind of become a little bit challenging. So I find a Tidepool platform very, very useful because it is a single platform where many glucometers can be uploaded. And this is Tidepool upload of one of my child with type 1 diabetes, 18-year-old. So you have this color-coded kind of blood sugar readings. You have distribution of these readings in time in range, above range, and below range. You have average glucose as well as measures of glycemic variability such as standard deviation and CV. You can also see trends of glucose. So it is, I mean, when we are having cost constraints with respect to CGM, if you're using glucometer and if you're uploading it on such websites, then you can also get a graphical representation of, so in one view, you can tell that this particular boy is having high glucose in the first half of night, probably having some snacking while he's studying. And then throughout the day, these glucose readings seem okay. Although the caveat here is that if you look carefully at this graph, look at the number of blood sugar readings that this boy is doing. So clearly that is not enough. So if you're using glucometer, ISPAT guidelines recommend doing 6 to 10 tests every day. But I would say somewhere between 4 to 6 at least have to be done. Otherwise, it becomes like if you have very less data, it becomes meaningless. Coming to several mobile applications for logging your blood glucose. So there are all said and done, there are challenges in maintaining a manual glucose log. Often these logs are incomplete. They are not brought to the clinic for people will give a lot of excuses that they forgot or last minute they didn't remember, all that kind of thing. To interpret the data while you are in a busy clinic, it becomes difficult. Sometimes there might be a tendency to focus on extreme values. You immediately kind of automatically focus on low and high glucose readings, and you may forget the larger picture that 70–80% of the readings are okay. Also, if the data is not enough, you can't really conclude anything if there are no remarks or insulin doses not being mentioned. So these are the 4 applications that I have used. The Ipsomed has this My Life app. This is My Sugar app from Roche. My Sugar, I just recently discovered that the Indian app, they do not have the bolus advisor in it, whereas the Western app has bolus advisor. So I've insisted that why should India, which is technologically a much superior country, I would say, in terms of using technology, why should this not be available for Indian people? Diabetes M is also a comprehensive, quite comprehensive app, but it requires a little bit more intelligent and motivated person to use this app because there's a lot of fields to be filled in. This My Sugar Diary app also, I've found it to be extremely simple and extremely useful. I'll just give you, so this app doesn't have anything else. I mean, you just put in the insulin dose and you put in the blood sugar readings, and you can get the data in a nice Excel format, which can be color coded. You can decide the limits about what the low and high glucose would be. And this is something which I found very simple. And immediately at one glance, you can pick up any trends, abnormal trends or patterns of glucose. Like in this particular, it is not very difficult to make out the trend because all the readings seem to be. Although I think in terms of setting the limit, this person has not kind of set the limits, either set 2 ideal limits, because even 114 is seen as red, which is not the case. So, but overall, you can see that largely the readings are high. There is a comment, there is a section on remarks also, which has not come in this particular screenshot, but you can add remarks to explain these high or low readings. Coming to CGMS, CGMS has been one of the most important advances in the recent years in diabetes management. CGMS, I mean, I don't need to explain the basics that it's monitoring of interstitial glucose. And there has been significant evolution of CGMS technology right from its first introduction to 1999. And now the current devices do not need calibration. And some of these devices are approved for use without it being needed to be confirmed with SMBG, such as Dexcom G5 onwards. I think it is approved for use without glucometer. Also Libre 3 and Libre 2. Unfortunately, these devices, Dexcom G5, 6, 7, or Libre 2 or 3, are not available for us in India. But hopefully in near future, they will be available. Recently, Eversense implantable CGMS has received FDA approval. This was a very recent news item. So this is an implantable glucometer, which is like put with a minor procedure, and it is approved for up to 365 days. So for 1 year, it will continuously give the blood glucose, interstitial glucose data. Previously also a 6-month version was approved, but now 1-year version has been approved. Now, coming to the data analysis. Now, we'll just learn it with the help of 2 cases, one on CGM and the other one on hybrid closed loop pump therapy. This girl I recently saw in the OPD, 23-year-old. She has diabetes. She developed diabetes when she was 13. She takes Glargine twice a day, and she takes Lispro thrice a day. I'm sorry for the spelling mistake. She weighs 52 kg and her HbA1c is 8.1. So if you're sitting in the clinic and you have this blood sugar data, which is not very ideal, but at the same time, it's not too bad. I mean, at least she has done readings and she has noted down the readings. So you should appreciate your patients for doing what they have done. At least even if they get something to you, it is good. So what can you conclude? Can you tell me what is going on? I mean, wiser HbA1c 8.1. Well, there is a particular pattern of false readings. I mean, in this, I don't have a suspicion of false readings. It is possible. I mean, some of these readings could be fabricated, but usually if you see false readings, they always end up with 000 or 555, or they're very uniform. One of the possibility is that the readings are false, but second possibility is also that the blood glucose monitoring doesn't give us the whole picture. Also, even if, let us say, the HbA1c was okay, even HbA1c alone doesn't give us the whole picture. But when you see the CGM, now how do we go about? If you have CGM, there are two parts of CGM which are very important. One is ambulatory glucose profile page. This is what is the composite diagram of the 14, 15 days of data. And the second is daily curves. These two parts of CGM report are very, very important. So firstly, you confirm that it is the same patient or same person who is in front of you, that the data is of the same person. And you also see the dates, because now CGM is being used continuously. So you have to see which dates you're analyzing. And then you see this profile. And then on this, you mark the meal timings, breakfast, lunch, dinner, and exercise timings. So you make some markings, you note down the doses that the person is taking. And now you see the data in parts. You firstly see the night, then you see the pre and post meal periods, and pre and post exercise periods. Can you make any observations out of this? The next step is to look at risk or occurrence of hypoglycemia. And then the fourth step would be to recognize patterns of hyperglycemia. So what do you see? According to me, the most significant finding here would be that the 50th centile is crossing the lower limit here. So in the later half of the night, there is a significant hypoglycemia risk. Also, the second important pattern that I'm observing here is that there is a post-lunch hyperglycemia, followed by a sharp drop, leading to almost low normal kind of values around 10 o'clock. And this is coinciding with the exercise. So I would be curious to know the daily profile. So whatever you see in this summary, you corroborate in the daily profile. Now, are you seeing a pattern here? Whatever you are seeing has been happening on most of the days. So you see a pattern of nocturnal hypoglycemia. So what could possibly be going wrong? Remember that she's going to gym at 8:45 p.m. And if she takes the same dose of Lispro and same dose of Glargine on the days she's exercising versus on the days which she is not exercising, she's going to end up having hypoglycemia. So clearly, she needs to be taught about insulin adjustments for exercise, the post-exercise dinner time Lispro reduction, as well as maybe she needs Glargine dose reduction also on the days she's exercising. Also, the second pattern is hyperglycemias in post-lunch period. So here you need to, she is taking relatively fixed doses of Lispro, but the meals may not be fixed. So you have to look at the insulin carb ratios or carb content of her meals. Also, sometimes hyperglycemia occur as a result of treatment of hypoglycemia. So invariably, whenever there is a hyperglycemia, please look into the insulin dose, insulin timing in relation to the meal, and occurrence of hypoglycemia before the hyperglycemia. So I find that these three are the common reasons. And all this knowledge has come to me only after I've started using CGM. On a blood glucose diary, yes, we used to make some interpretations, but it is much more done in a better or more professional, better way using CGMS. So you would advise and educate her on exercise management, and hopefully that will sort out her problems. Now, coming to the case, a child who is on hybrid closed loop pump therapy. I'm not going to talk about details of insulin pump because I'll stick to the blood glucose monitoring part of it. Now, this is a 16-year-old girl with type 1 diabetes of 8-year duration. She is using the 780G pump for the last 2 years. She otherwise has normal growth, no comorbid conditions. Weighs 47 kg. Her height is normal. She's had menarche and regular periods now. Her A1C is 8.7, but her time in range is 89%. So sometimes it can happen that there's discrepancy in the time in range and HbA1c. Then I see the smart guard settings. Smart guard is the automatic mode or automatic program of the pump. And the settings are optimum. Optimum definition of optimum settings on smart guard is blood glucose target of 100 and active insulin time of 2 hours. In the previously used pumps, we used to keep active insulin pump of time, active insulin time of 3 hours or 4 hours. But in HCL, we keep active insulin time of 2 hours. Or maybe sometimes 2 hours, 15 minutes or 30 minutes if there are too many hypoglycemia. Now, the parents were very angry with the pump company and also to some extent to me that we thought that we are using the best device, but her HbA1c used to be much better when she was on the previous pump or some even on basal bolus treatment. So I had presented this case long ago, I think in Mumbai, and one of the, I think it was somebody from SGPJ only who pointed out that we should do HB electrophoresis. And HB electrophoresis was indeed done for this girl and it was normal. So this is her download from the pump CareLink profile, CareLink website. CareLink is also something which people should be aware of when using the Medtronic systems. So these blue curves are the recent 14 days and the orange curves are the previous 14 days. They're superimposed on each other. The dotted line is the 50th centile. The blue, the colored blue area is the 25th and 75th centile. And the blue lines are the 10th and 90th centile of the data. So only 80% of data is presented in AGP. You can see that it's perfect. She has 91%, 87% time in range, very good time in range. The blood glucose lines are flat. There's hardly not much of variation in the blood glucose profile. Now, what are the other components that you will see? So these bars represent the time in range, above range, and below range. In above and below, again, you have stage 1 and stage 2 hyperglycemia and hypoglycemia both. This particular column is giving smart guard exits. That is the number of times the pump exited from the automatic mode into manual mode as a backup. So this has happened once because the sensor was expired here. So it has happened once here and once here because there was no calibration done. Now she's using Guardian 3 CGMS, which requires calibration. The latest Guardian 4 CGM is calibration is not mandatory in the Guardian 4 CGM, but she was on Guardian 3. Then on the right side table, you basically see whether the person is using smart guard enough. Ideally, we want them to use it at least 85, 90% of the times. She's using 100% of the times. Manual mode is 0%. And most of the time, she is wearing the sensor. So 97% of the times, she is wearing the sensor. Then you also see what carbs were entered and what is the active insulin time. And it also gives a lot of other readings like average glucose, GMI, that is glycemia measurement indicator, that is considered as the equivalent of HbA1c. The variation, the variability in terms of CV, the average BG. Now here, average SG is average sensor glucose, and average BG is the blood glucose that is was entered as calibration readings. Then it gives total daily dose, bolus amount, auto correction amount, auto basal or total basal amount per day, and the reservoir changes. So this data is important to make interpretations out of this analysis. Whatever observations you make, again, you have to cross-check the daily curves. And in daily curves, you can see the calibration and you can pick up some highs and lows. I mean, in this, everything is perfect. I mean, we were baffled about what is exactly happening. And we had to discuss this with the Medtronic team, and they have also forwarded to some of their medical experts who kind of pointed out that there is, I mean, if you go back to this, the average sensor glucose is 131 and average blood glucose is 132. Similarly, here also, there's hardly like 130 and 132. So he said that we should cross-check how is the child calibrating the sensor. And we discovered that she was calibrating the sensor using the sensor glucose value itself. So she was not actually doing a glucometer value. So she was calibrating the sensor using the sensor glucose. So obviously the sensor itself was a standard for the sensor. So everything was perfect. And the estimated HbA1c and time in range was perfect. So after we kind of tried to correct this problem, now you can see that although time in range has dropped a little bit, HbA1c has improved. And now you see that the readings are not ideal. You see that there is some variation. There are some challenges probably in the insulin carb ratio and in the meal. So this is how you go about analyzing data. I think in the initial few CGMs, you will require to spend maybe 20 minutes, 30 minutes per CGM. So you should have that much patience. And once you become an expert, then you will just see the CGM and make a diagnosis. But I think initial few CGMs, you have to really take a lot of efforts and go in a systematic manner. Identify the patient, identify the correctness of the data, then put these linings and markings of meals, exercise, insulin dose, etc. Have some notes about what happened on what particular day. Encourage people to keep a diary where they write down whether they went for a party, whether they had some sweets, or whether they, whatever comments. So that really helps to educate us and also to educate these people with type 1 diabetes. So to summarize, there have been significant technological advances of type 1 diabetes in the recent past. And there is now data available to show that this technology has helped in improving, reducing the rates of severe hypoglycemia, improved HbA1c, and also like better time in range. We need to have an unhurried kind of stepwise approach to interpret the data for decision making as well as for patient education. Thank you so much for